Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Myrna Weissman, who is the founder of the therapeutic model, Interpersonal Psychotherapy, which is commonly referred to as IPT. Dr. Weissman is the author of many seminal books, including The Guide to Interpersonal Psychotherapy, which is used by therapists all over the world to improve the lives of their clients. Dr. Weissman, welcome to The Therapy Show.
Thank you. Look forward to talking with you all.
Can you start by telling us a bit about your personal and professional background that led to the development of IPT?
Well, it's a small story. When I had just finished school of social work, I took a job 2 days a week. We had just moved to New Haven, to Yale University, and the job was to work on the first clinical trial of medication and psychotherapy. And it was run by Gerald Klerman, who was on the faculty there, and I was supposed to help them in designing the psychotherapy. At that point, there were no manuals for psychotherapy. There were no clinical trials of psychotherapy. And Jerry felt that if we were going to be able to test something, we had to write it down in a manual to say what the procedures were, and that we had to be able to train people using these manuals, and then we had to do clinical trials, as you would with medication, to make sure the treatments really worked. And if they weren't efficacious, we shouldn't recommend them. Jerry had a strong background in pharmacology. He had run some of the major clinical trials in psychopharmacology, and he felt that psychotherapy could have the same standards. So he set me out to help design the psychotherapy. I didn't have that much experience in psychotherapy at all, but I had been working in the psychopharm clinic and started out designing a therapy that had what you would call a medical model, which was that you would do a diagnosis, you would take a history, you would take a social history to find out who was in the patient's life, you would find out when the symptoms began and what was going on in the patient's life when they had these symptoms. And that was the beginning of IPT. Before the trials were finished, we called it high contact. After we had a success and showed that it was efficacious, we then developed the name Interpersonal Psychotherapy, because essentially that was what it was about.
How would you briefly explain IPT to a non-professional?
The idea behind interpersonal psychotherapy is that no matter what your background is, and we know people sometimes have very difficult childhoods and backgrounds, that symptoms develop in an interpersonal social context. Something is going on in the patient's life. The idea with interpersonal psychotherapy is to understand what that is and to try to help the patient develop strategies for dealing with it in order to reduce the symptoms. IPT has 3 phases. In the first phase, we do a history. We do what's called an interpersonal inventory, which is find out who is in your life, who are the people that are helpful, and who are the people who perhaps are the context of the problems. We then try to get a sense of when the symptoms began and what was going on in the patient's life when the onset of the symptoms occurred. Give the patient what we call the sick role, which is you are not responsible. It is not your fault that you're depressed, but that something is going on in your life that is contributing to your symptoms, and that you're getting help. You should take care of yourself during this period and not put too much pressure on yourself, but you've also taken the first step towards getting help and alleviating the symptoms. Then we make a contract with the patient and we set a time limit. We feel that therapy shouldn't go on forever and that we should have certain goals within a certain time period. We set that time limit with the idea that at the end of that time, we reevaluate where the patient is, whether they've gotten better, and if not, what other treatments they might need, more medication, less medication, more different psychotherapies, etc. And then we renegotiate what they need for the future, if anything. We then identify one of 4 problem areas, which are grief, disputes, role transitions, changes in your life, or finally loneliness. And we help the patient first of all, to define what the problems are with the onset of the symptoms. And these problems may change, and there also may be more than one problem. But we have strategies for dealing with each of these problem areas. And that's what the middle phase is about. When the patient comes for the interview, each time we ask them how they're feeling. And if they say, I've been fighting with my husband, then we ask about their symptoms. If they say, I'm just not sleeping and eating, then we ask what was going on in their life. In other words, we try to help the patient make a link between their symptoms and their problems in current living. At the termination period, we do a review of what's been gained and what's not been gained, what more needs to be done, and we decide with them what kind of future treatment, if any, is necessary. That's it in a nutshell.
When and how did you realize that IPT would be an effective form of therapeutic intervention?
Well, we were very clear that we didn't have beliefs. We had to have clinical trials. And the first clinical trial was the maintenance study, the one that IPT was developed for. And in fact, we didn't think it would work because there hadn't been one clinical trial that showed that psychotherapy worked. But there was papers by, I think, in which he had looked at 700 cases and he said, there's no efficacy for psychotherapy. And they weren't manuals, so there was no real way of testing it. But we were not sure that this would work at all. But we found that not only did it worked exactly as we thought it would, which was the medication helped the patient's symptoms, namely the sleep and the appetite and the anxiety problems, and IPT helped with social functioning, who they were getting along with and how they felt in their relationships. After that study was done, we said, well, one study's not enough. If this were medication, you would have to have at least 2 clinical trials. So we designed another study, an acute treatment trial, and again, the results were positive. So we felt we were onto something that was effective. Then we felt it was very important that this be done by other groups because we were the group that invented it, and therefore we might be biased, although we tried not to be. We did controlled clinical trials. And a series of studies then were done by the Pittsburgh group, David Kupfer and Ellen Frank, and they were doing studies on recurrent depression, and they also had positive results. So we felt we have an efficacious treatment.
So who is IPT most effective for, and why should people choose an IPT intervention?
Well, first of all, there should not be one treatment. You wouldn't want to have just Prozac. You're glad that there's many different kinds of antidepressants. In fact, for the statins, there's many different kinds of statins. And I really believe that it's important for psychotherapy that there's different kinds of psychotherapy as long as they're evidence-based. And at the same time that IPT was developing, Aaron Beck was developing cognitive therapy, and Gerald Klerman and Aaron Beck were friends. They just had a different perspective. Cognitive therapy came from the behavioral literature, and it was based on changing one's thinking. IPT was based on the life events literature, which was then focused on trying to understand the life events that were going on that might have precipitated these symptoms. Since then, there's about, I'd say, 10, maybe 8 or 10 other psychotherapies that have had efficacious results. Now, I think IPT works best for people with depression who've had discernible life events. It works very well with adolescents, and also it works very well with the elderly. There's good evidence that works with people with eating disorders. It's a little bit slower than behavioral therapy, but in the long run, the effects were actually slightly better. It does not work with people who have drug addiction because drug addiction is not an interpersonal problem. It's an addictive problem. It might help after the person is in recovery to deal with the impaired relationships. It works very well in groups. It works beautifully in low-income countries where it's been tested in a number of places like Uganda and Ethiopia, where there's very few resources for mental health. If a person has no life events going on, they're just chronically depressed, it works less well unless medication is added.
I read somewhere that it works well with personality disorders.
I think there's one study. I can't say that it does.
So what's the average length of treatment for somebody working with IPT?
Well, that's a good question, but we really don't know. The point we have is that it has to be time limited with a time determined at the beginning. We use 12 to 16 weeks for an acute episode. For patients with severe recurrent depression, they use monthly for 3 years, showed that they were able to keep symptoms at bay with monthly treatment. That was very important because of, if a woman wants to become pregnant and has severe recurrent depression, if they can keep her asymptomatic for a period of time while she's pregnant, that is very good. And perhaps doesn't need to use medication during that period. The important thing is having a time limit. Psychotherapy is not a career, and that it is there to solve problems. And if you have a time limit, you determine the progress you've made and reevaluate whether it's sufficient progress or whether something else might be needed.
So what skills, habits, or tactics can patients and therapists adopt either during their sessions or in between sessions to improve the effectiveness of IPT?
Well, if you have a well-trained therapist, who sticks to the script, that should be good. I don't really know the answer to that, but it's to keep the focus on the current problems and not get diverted by issues that may not help those. One of the things I've seen in supervising residents and, listening to cases is that the tendency to blame. And there's no question that people who've had abusive childhood or parents who are cold and not encouraging, they have a harder time. However, if the focus is always on blaming the past rather than trying to rescue the future, I think that less progress is made. So I'd say that you recognize the person's background, their context, but the goal should be on what you can do to help move towards a solution. And that usually means being able to talk about it, to express one's wishes and needs directly to those people who are close, the patient is close to, but feels maybe they can't talk to develop alternate relationships if those don't work, to try to deal with disputes with children, with job, to deal with changes in one's life that may be negative but also may have some positive consequences, to deal with the issues at hand. And I think that is what makes for a better outcome. It's not possible. We can't cure everybody. In fact, you cure nobody. You just help a person with their life.
What are the most common obstacles and or mishaps that prevent therapists and patients alike from seeing the full benefits of IPT?
Well, if we can't get a patient to express their wishes and needs or to express their anger and frustration directly, and then to take steps to deal with those problems in their lives, then we don't make much progress. And it's also very important to try to alleviate the symptoms of depression, and that often is done by medication as an ancillary to the treatment. Because if a person is very depressed, they're hopeless and helpless, and they think nothing's going to work anyway. So it's usually a combination.
So who is IPT not appropriate for?
Well, someone who has acute alcoholism or drug abuse, they should go into remission before it just doesn't work. People who have psychotic depression don't do well unless they have medication to reduce that. People who have nothing in their lives, no relationships, they have nothing to talk about, I think they may do better in cognitive therapy. I haven't tested this, but that's my hunch. If somebody is totally devoid of relationships, and we deal with it in the fourth problem area of loneliness and interpersonal deficits. And we try to do role playing. How do you approach a crowd? What groups could you get into? I'm not sure how successful we are with that. And, cognitive therapy may help, or group therapy might help with that.
So what are you most excited about in mental health treatment today?
Well, I'm most excited about the U.S. Preventive Task Force that came out in February 2019 in JAMA, in which they finally have said that we ought to do something to prevent depression and deal with mild symptoms in pregnant women. And they recommended CBT or IPT as the treatments. And I think that is the most exciting thing I've seen. First of all, there's a high rate of depression, pregnancy, and postpartum. The effect on the fetus is not good. The effect of using medication is controversial. We've actually done those studies, and we're not sure we would recommend medication. I mean, sometimes you have to, there's no choice, but certainly not for the mild symptoms of depression. And we know that a mother's depressive mood has a very negative effect on the children. We've done studies of that, and we've shown that if the mother, her symptoms improve, the children improve. So why not begin before she has the child and set a good atmosphere for the birth and for infancy? So that was very exciting that they strongly recommended in a medical journal IPT or CBT. Everyone should read that. JAMA, February 2019. That is very important, and I hope the word gets out. There's a recommendation to screen all pregnant women for depression. Well, that's fine, but then what do you do? And the first task force that came out 2 years ago said do screening, but it didn't say what to do with it, except give medication maybe. Now I think what they recommend is there be a psychological intervention. I would like to see that if a woman screens positive on depression during her pregnancy, that she is immediately offered 4 sessions of IPT or CBT. And we know in HIV treatment, if somebody is diagnosed with HIV and they're offered treatment right at the moment of the diagnosis, right there, they take it and they're more apt to sustain it. If they're told, come back in a week and you'll go see somebody else or another clinic, the dropout rate is very high. And I think that would be the same with pregnant women who are depressed. And I think that we could meet those needs if we could use community health workers who are trained to administer IPT or CBT. We can do that in Uganda, and we're doing it in Mozambique, but there are barriers to doing that in medical clinics here in the United States.
And what would those barriers be?
Well, I haven't studied all the places, but there's, legal issues.
Okay. So if you had a magic wand and could improve one thing about mental health treatment today, what would that be?
More money for research, more money for clinical trials, more money for research.
So how can my audience learn more about IPT, either online or in print?
Well, they can buy my book, which is Weissman, Markowitz, or Klerman. Klerman was my deceased husband. It's called The Guide to Interpersonal Psychotherapy. It's Oxford Press. It's a paperback, and it's 2018, and it's available on Amazon.com.
And there will be a link to your book on the website. Dr. Weissman, on behalf of myself, my listeners, and all of the people that you have helped through your work with IPT, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of interpersonal psychotherapy.
Well, it's been a pleasure to talk about it, and I would like to see your dissertation when you publish it.
Actually, not a dissertation. It's a multimedia project, which is what you're part of, and it's for the consumer. It's basically to help the consumer have more knowledge about research-based and evidence-based treatments like IPT, which really work, and I'm very passionate about that.
Yeah, that's a great way to have it available to the consumer. That's very novel, and you're to be congratulated on that.
Oh, thank you. I really feel good about it. I do. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you or someone you love and the people around the world can benefit from therapies like IPT. There's no need to suffer in silence. Get the help that you need to create the life that you want.